Welcome to the deep dive. Today we're tackling a really important area, especially if you've got the MSRA exams coming up, Budd-Chiari syndrome or BCS.
Mhm.
It's maybe not something you encounter daily, but well, getting a good handle on it is pretty key for sharp clinical practice.
Absolutely. Think of BCS as, well, it's a rare condition, but it's a significant one. It messes with the liver's drainage system.
Right.
We're talking about a blockage or maybe a narrowing of the hepatic veins. Those are the vessels carrying blood away from the liver.
Okay.
And this outflow problem, it can pop up suddenly, acutely, or develop more slowly, chronically. It might just be one vein, or it could affect several.
And I suppose what makes it a bit tricky diagnostically is how differently it can show up. It's not always the classic picture.
Exactly. That's why you've got to have it on your radar, when dealing with both acute and chronic liver problems.
Makes sense.
Plus, it's really crucial to tell it apart from things that can look similar, like hepatic veno-occlusive disease, especially after stem cell transplants. We see that sometimes.
Ah, right. That distinction.
Yeah. And interestingly, for some of the chronic types, there might even be a genetic link, often tied to those myeloproliferative disorders.
Okay.
So our mission today really is to just boil down the essential knowledge about Budd-Chiari from these revision notes you've got.
Right.
We want to pull out the core stuff in a way that, actually sticks. And maybe we can throw in a few memory aids, mnemonics, that sort of thing to help you nail it in an exam.
Perfect. Okay, let's dive right into the definition then. So fundamentally, Budd-Chiari syndrome is this rare thing where the hepatic veins, the liver's outflow pipes get blocked or narrowed, blood flow out is impeded.
And like we said, it can be acute, bang, sudden onset, or more chronic, creeping up gradually. And it could affect just one or multiple veins.
And the presentation varies hugely.
Hugely. It's why you just have to think about it across that whole spectrum of liver disease, fast or slow.
Yeah.
And again, that difference from veno-occlusive disease, post-transplant especially, that's super important to keep straight.
Good.
And don't forget, in some chronic cases, especially if there's a myeloproliferative disease involved, there could be an underlying genetic component.
Right. Okay, now causes.
Yeah.
Etiology. What actually leads to this hepatic traffic jam? Seems like there are quite a few potential pathways.
There really are. The causes are pretty varied, but we can sort of lump them into categories. By far, the most common culprit is thrombosis.
Blood clot.
Exactly. A blood clot forming either right there in the hepatic veins or sometimes even in the big one, the inferior vena cava, where the blood's returning to the heart.
Okay, thrombosis first.
Yeah.
Then there's a big group. Hematological causes, right? Blood-related issues.
Yes, and this is a really key area. You need to think about things like Polycythaemia vera, other myeloproliferative disorders.
Where you make too many blood cells.
Precisely. Makes the blood thicker, more prone to clotting. Then you've got the prothrombotic states conditions where you just have a higher tendency to clot.
Like inherited things.
Yeah, inherited or acquired. Think deficiencies in protein C, protein S, antithrombin the third. Factor V Leiden mutation is a big one.
Okay.
Also, antiphospholipid antibody syndrome, essential thrombocytosis, paroxysmal nocturnal haemoglobinuria, even after a bone marrow transplant sometimes.
Wow, that's quite a list to remember. Is there a trick for that, for the MSRA?
Yeah, we can try a mnemonic. How about my proliferation and clotting crew?
Okay.
My proliferation for the myeloproliferative disorders, clotting for the protein C antithrombin deficiencies, and factor V Leiden. And crew is just a catch-all for the rest, like antiphospholipid syndrome, PNH, the others on that list.
My proliferation and clotting crew. I like it. Okay, what else besides clots and blood disorders?
Well, another group involves reduced blood flow. This could be a structural problem with the vena cava itself, maybe a web or something.
Wow.
Or it could be cardiac. Issues where the heart isn't pumping effectively, like right heart failure or constrictive pericarditis. Blood backs up into the liver.
Okay, heart issues. And I see obstetric causes listed too.
Yes. Pregnancy and the postpartum period, the hormonal changes, the increased pressure, sometimes that can contribute to BCS developing.
Interesting. What about drugs?
Yep. Certain meds have been linked, combined oral contraceptives, hormone replacement therapy, even a chemical called urethane, though that's less common now.
And this one seems odd. Infections.
Yeah, it can happen. Certain infections can trigger inflammation that affects the veins. Things like hydatid disease, amoebic abscesses, aspergillosis, even syphilis or TB in some cases.
Goodness, the list keeps going. Chronic inflammatory conditions.
A whole range of autoimmune and inflammatory diseases. Inflammatory bowel disease, sarcoidosis, lupus, Sjögren's, Behçet's disease, mixed connective tissue disease. They've all been associated.
And unfortunately, malignancy as well.
Sadly, yes. Cancers like hepatocellular carcinoma, renal cell carcinoma, Wilms tumor, adrenal carcinoma, leiomyosarcoma, they can sometimes grow into or compress the hepatic veins.
Okay. And lastly, this sort of catch-all other causes category.
Right. Exactly. Things like trauma, maybe after surgery, alpha-1 antitrypsin deficiency is in there too. And importantly, in maybe, 30% of cases, we actually can't find a specific cause.
Really?
30%.
Yeah, that's idiopathic BCS. It just shows there's still quite a bit we don't fully understand about why it happens sometimes.
Okay. So, loads of potential causes. What actually bumps up someone's risk? What are the key risk factors we should think about? Well, the biggest ones are definitely having those underlying prothrombotic disorders, the conditions that make your blood clot more easily.
Like the factor V Leiden you mentioned.
Exactly. Factor V Leiden mutation, antiphospholipid antibodies, those are really key. But other things add risk too, like using oral contraceptives, being pregnant, having had recent surgery, or even having pre-existing liver disease.
Right. So, okay, the veins get blocked. What actually happens then? Can you walk us through the pathophysiology?
Sure. So when those hepatic veins get obstructed, it's like, damming a river. Blood can't get out of the liver properly.
Pressure builds up.
Pressure builds up, exactly. You get congestion, impaired drainage. This starts to damage the liver cells themselves, and the liver swells up. That's the hepatomegaly you might feel.
And does the body try to sort of fight back, compensate?
It does, yeah. It tries to create detours, basically. Develops what we call collateral vessels, alternative routes for the blood to escape the liver.
Like little bypasses?
Kind of, yeah. But often it's not enough. Over time, this ongoing congestion and cell damage leads to fibrosis, scar tissue forming in the liver.
And that can lead to...
If it keeps going, yeah, it can progress to cirrhosis that's more severe, often irreversible liver damage.
This really sounds like it could look like a lot of other liver issues. The differential diagnosis must be pretty broad.
Oh, absolutely. That's a critical point, especially for exams. The symptoms overlap so much. So naturally think of other liver stuff first. Cirrhosis from other causes, portal hypertension, maybe a clot in the portal vein instead of the hepatic veins. And always keep hepatic veno-occlusive disease in mind, especially post-bone marrow transplant. Remember where the block is before, within, or after the sinusoids. That helps differentiate.
Right. Location matters. What else is on the list?
Well, cardiac problems, like we mentioned, with causes of right-sided heart failure, constrictive pericarditis, they can cause liver congestion too, mimicking BCS.
Okay.
And then surprisingly, maybe things like acute appendicitis, biliary atresia, chronic granulomatous disease, congenital hepatic fibrosis, cystic fibrosis, CMV infection, gosh, even things like intestinal malrotation, intussusception, kidney issues like nephrotic syndrome, pancreatitis, some infections like syphilis, toxo.
Wow. Okay. That's a long list. How do you even begin to organize that mentally?
Yeah, it's daunting. The best way is probably to categorize broadly. Think other liver diseases, cardiac causes, acute abdominal things, and infections. Having those big buckets can help you run through the possibilities systematically.
Good tip. Okay, so how common is this? What's the epidemiology?
It's definitely rare. We don't have super precise UK figures, but the estimate is somewhere between, say, 1 in 100,000 and maybe 1 in a million people per year. It's quite uncommon.
And who gets it? Any particular age group?
It can happen at any age, really, but it's most often diagnosed in adults, usually in their 20s up to their 50s. That's the peak time.
Are there any sort of geographical quirks? Does it look different around the world?
Yeah, there are some interesting variations. For instance, the idiopathic kind, where we don't find a cause, seems a bit more common in South Asia. Whereas in Western countries, we more often pinpoint one of those hypercoagulable disorders as the cause, and then you get region-specific links, like hydatid disease or Behçet's disease being more associated with BCS in places like Turkey. So yeah, environment, maybe genetics, they play a role.
Right. Let's get to the patient presentation. What are the typical clinical features? What signs and symptoms should make us think, could this be Budd-Chiari?
Well, the common things you might see are hepatomegaly, that enlarged, maybe tender liver. Ascites the fluid buildup in the belly, making it distended, and often sudden, quite severe abdominal pain.
Pain, ascites, big liver.
That's often the core picture. Jaundice, the yellowing, can happen too. And signs of liver dysfunction on blood tests, raised enzymes, clotting problems. In the really severe, rapid cases, it can unfortunately progress to acute liver failure.
Is that the classic triad I've heard about?
Yes, that classic triad often quoted is 1. Sudden severe abdominal pain, 2. Ascites, and 3. Tender hepatomegaly.
But you said it's not always that neat.
Definitely not. It's important to remember that while the triad is typical, BCS can present much more variably. You need a degree of suspicion even without all three.
Right.
You usually need several veins blocked before symptoms really kick in. The acute form presents dramatically. Sudden severe pain, fast ascites, big liver, jaundice, maybe kidney injury, potential liver failure.
And the slower version.
The more gradual onset often features ascites as the main thing. Jaundice might actually be absent. Interestingly, about half of those gradual cases also get some renal impairment. And you might also see other signs like dilated veins visible on the abdomen or chest wall, those collaterals trying to bypass the blockage, and sometimes an enlarged spleen, splenomegaly. So yeah, quite a mix of possibilities. High index of suspicion is key.
Okay, so suspicion is high based on a clinical picture. How do we confirm it? What investigations do we use?
Diagnosis really relies on putting pieces together, but imaging is absolutely central.
Ultrasound first.
Yeah, ultrasound with Doppler flow studies is usually the first port of call. It's pretty sensitive for picking up abnormal blood flow in those hepatic veins, and you can often see the veins themselves, maybe even a clot.
Okay, what else?
CT and MRI give you really detailed pictures of the liver and the whole venous system. MRI is often preferred, actually. Better soft tissue detail, can visualize flow better without contrast sometimes. And you can even do 3D MRI angiography for a really good map of the vessels.
And what about blood tests? What are we looking for there?
Bloods are important, but can be a bit nonspecific on their own. LFTs, the liver function tests, might show raised enzymes, but, and this is a key point, sometimes they're only mildly elevated.
Not sky high like in some other acute liver injuries.
Exactly. That can be a clue. Prothrombin time, checking clotting, might be prolonged. If there's ascites, you can tap it due to paracentesis. The fluid in BCS often has a high protein content, but you always have to weigh the risks of the procedure, of course.
Yeah. Are there any really specific radio imaging signs that shout Budd-Chiari?
Yes, there are a few classic things to look for. On MRI, you might see a prominent caudate lobe. That's a specific part of the liver that often gets bigger because its drainage pathway is sometimes spare.
Okay, caudate.
On Doppler ultrasound, you might see no flow or even reversed flow in the hepatic veins. You might see the thrombus itself or those collateral vessels we talked about. And you might see the caudate lobe hypertrophy on ultrasound too. Occasionally, you might do a caval venography injecting dye into the veins to specifically look for webs or blockages in the IVC or hepatic veins, but that's less common now with good non-invasive imaging.
And what about a liver biopsy? Is that needed?
It can be very helpful. It gives you tissue to look at under the microscope. The typical finding in BCS is called centrilobular congestion, basically. The areas around the central veins in the liver lobules are all backed up with blood.
Okay.
It's not always 100% diagnostic on its own, but combined with the clinical picture and the imaging, it really strengthens the diagnosis and tells you how much damage there is. So yeah, usually diagnosis involves imaging, bloods, and often a biopsy.
Okay, diagnosis confirmed. How do we manage Budd-Chiari syndrome? What are the goals?
Right, management. The main goals are 1, relieve that obstruction in the veins, 2, try and preserve whatever liver function is left, and 3, manage any complications that crop up.
And how do we do that?
It's a mix of things. Medical therapy, interventional radiology, sometimes surgery. Anticoagulation is absolutely key. Blood thinners to stop more clots forming or growing. That's usually first line.
Okay, stop the clotting.
Then you've got procedures to physically open things up. Angioplasty, using a balloon to stretch the narrowed vein. Putting in a stent to keep it open. Sometimes surgical shunts are needed to create a whole new path for blood flow out of the liver.
Like bypassing the blockage.
Exactly. And in really severe cases where the liver is badly damaged and failing, liver transplantation might be the only option left.
And symptom control?
Oh, yes, definitely.
Yeah.
Using diuretics, water tablets to help manage the ascites, and a low-salt diet is important for that too, reducing fluid retention.
Is there a sort of standard order you do these treatments in, a stepwise approach?
Generally, yes. First, you always try and figure out why it happened to treat the underlying cause if you can, like the prothrombotic disorder. Then, medical treatment. Anticoagulation right away. If that's not enough, or if there's a really tight blockage, you move to endovascular treatment.
The angioplasty, stenting.
Yeah, or maybe thrombolysis, using clot-busting drugs right at the clot site. Or creating a TIPS,
What's TIPS again?
transjugular intrahepatic portosystemic shunt. It's where they make a channel, usually via a needle through the jugular vein, connecting a portal vein branch inside the liver to a hepatic vein branch. Bypasses the main blockage.
Okay.
If even that doesn't relieve the congestion enough, then you might need surgical decompression, maybe a TPS done surgically, or other types of surgical shunts.
Right.
And if it's something specific, like an IVC web, then balloon angioplasty, maybe with a stent, can work really well. And like we said, transplant is for the end-stage cases, decompensated cirrhosis or acute liver failure.
Any other specific things to bear in mind for management?
Well, if someone has chronic clotting in the IVC, they'll likely need long-term warfarin. When doing thrombolysis, delivering it locally, right to the clot, is often preferred. Percutaneous angioplasty and stenting are very common now for narrowed veins. And sometimes, during a transplant, they might need to use bits of the patient's own vein to reconstruct the outflow autologous vein grafts for venoplasty.
Okay, that's quite a range of options. What about the outlook? What's the prognosis for someone diagnosed with BCS?
It really varies, depends heavily on the underlying cause, how much liver damage there was when they were diagnosed, and crucially, how quickly and effectively they get treated.
But it can be good.
It can be, yeah. If it's caught early and managed properly, restore that venous outflow, protect the liver, the prognosis can actually be quite favorable. Some reports suggest 5-year survival rates up to 90% with treatment.
That's really quite encouraging. What makes the prognosis worse?
Well, if the disease is already advanced when found, if there's significant cirrhosis already set in, needing a transplant, that's obviously a more serious situation. And developing complications like portal hypertension and variceal bleeding, that definitely worsens the outlook. And though they're rare, things like fulminant liver failure, or if the clot is related to a cancer invading the veins, those have a poor prognosis.
Okay. And finally, what are the main complications we need to watch out for in Budd-Chiari?
The big ones really stem from that chronic liver congestion and damage. You worry about hepatic failure, liver not working properly, leading to encephalopathy, confusion, clotting problems.
Right.
Portal hypertension is a major consequence. That increased pressure in the portal system leads to those esophageal varices, swollen veins in the gullet that can bleed really badly.
That sounds dangerous.
It is, yeah. Very dangerous. Other serious things include spontaneous bacterial peritonitis, SBP, which is an infection of the acidic fluid, and hepatorenal syndrome, where the kidneys start to fail because of the advanced liver disease.
Okay.
These complications cause a lot of problems, significant morbidity, and sadly can increase mortality. So, catching them early, managing them actively, and ongoing surveillance are absolutely vital.
Well, that certainly was a comprehensive deep dive into Budd-Chiari syndrome.
Yes.
We've gone through the definition, the many causes, risk factors, what actually happens pathologically, the huge differential is who gets it, how they might present, which is quite varied, the key investigations, all the management options from anticoagulation to TPS and transplant, the prognosis factors, and those serious complications. It's really clear you need a solid grasp of this for clinical practice and definitely for the MSRA.
Absolutely. And when you're revising, try putting yourself in the scenario. You get a question, patient comes in, new ascites, bit of tummy pain, LFTs are only slightly up. What questions pop into your head? What are your first tests going to be to think about BCS? Running through those kinds of practical steps really helps cement the knowledge.
Great advice. And of course, for more detailed revision resources, question banks, all that good stuff for the MSRA, do check out passthemsra.com and also freemsra.com.
Yeah, definitely worth a look. Ultimately, Budd-Chiari is a great example of one of those less common but really important conditions in medicine. Understanding it well means you can spot it, intervene quickly, and that can make a massive difference to patient outcomes. It really highlights why getting to grips with these rare diagnoses matters.